On behalf of the Department of Geriatrics, Mr. H, a 70-year-old man from Vellore, presented with complaints of slurring of speech and deviation of angle of mouth to the right on 20th of September 2024, which gradually improved. He presented to the hospital after 4 days on the 2nd, and on examination at that time, he did not have any deficits. Blood pressure was elevated. An MRI brain was done, which had shown an infarct. He was, however, not willing for admission at that time, and was discharged from ED on dual antiplatelets and hydrostatins. However, we later found out that he was irregular on discharge medications and he had taken Siddha medications and food restrictions. He presented again on after 2 weeks on 11th of October with slurring of speech for 3 days, inability to speak for 2 days, and inability to chew or swallow for 2 days. While at work, at 3 p.m., he had noticed a change in voice, hoarseness, and slurring of speech. And by 5 p.m., he had an inability to speak, but he was able to communicate by writing. By 10 p.m., he had deviation of angle of mouth to the left side, and he had difficulty chewing, swallowing food, and had drooling of saliva. There was no history of any limb weakness, but he was able to drive his two-wheeler back to his house. There were no sensory deficits, no loss of consciousness, altered sensorium, no headache, visual deficits, or seizures. There's no history of trauma. By the next day morning, he was completely unable to form words or speak, but he could make only minimal sounds. He was not a smoker or alcohol consumer, and he did not have any known comorbidities. There's no history of any fever, vomiting, cough, loose stools, etc. On examination, he was able to communicate to us clearly through writing. He was found to be conscious, alert, oriented to time, place, and person. He was noted to have noisy breathing. Vital signs were stable, and JVP was not elevated. He did not have a carotid bruit. The cardiovascular, respiratory, and abdomen examination were normal. CNS examination, he was unable to talk, but he could clearly understand what was said to him. He was able to communicate meaningfully through writing. On cranial examination, visual acuity and field were normal. Pupils were equal and reactive to light. He had upward gaze palsy bilaterally. He was unable to clench his teeth, but corneal reflex and facial sensations were normal, and jaw jerk was absent. He had deviation of angle of mouth to the left and inability to blow his cheeks. He was able to frown, but it was reduced on the right side. He had mild weakness of closure of the right eye, and nasolabial fold was also reduced on the right side. He had drooling of saliva and was unable to swallow. Gag was absent on the right side, and we were not able to visualize the uvula as we could not push down the tongue. He was unable to protrude the tongue or move it from side to side. Motor examination was normal. Bulk, tone, and power were normal. Reflexes were all 2+. Plantar were bilaterally flexor. Sensations were normal. Cerebellar and gait were also normal. So summarizing, the 70-year-old man with newly diagnosed diabetes and hypertension presented with complaints of sudden onset inability to speak and swallow with deviation of angle of mouth, with a history of similar transient complaints 2 weeks back. On examination, he had a complete inability to speak, with weakness of the motor components of 5, 7, 10, and 12 bilaterally, but there were no motor or sensory deficits, no pyramidal signs. So aphasia was initially considered as he couldn't speak at all. However, this didn't add up as he could communicate clearly through writing, and he also had involvement of multiple cranial nerves. Then medulla and pons were considered in view of this multiple cranial nerve involvement. However, there were no sensory deficits, there was no motor deficits also. Other differentials we consider were bilateral pseudobulbar palsy and bilateral orbicular syndrome. At presentation, we thought he had a stridor, so we had consulted ENT. However, bilateral vocal cords were normal, mobile, and airway was adequate. Investigations were grossly normal. HbA1c was 6.6, but others were normal. So we did a MRI acute stroke protocol, which shows acute infarct in the left centrum semiovale and a subacute infarct in the right centrum semiovale, which is what he had presented with in the first presentation. He also had grade 1 to 2 chronic small vessel ischemic changes and features of intracranial atherosclerosis. Carotid Doppler did not show any large vessel stenosis or occlusion. Platelet function analysis for aspirin and for clopidogrel were normal. Holter and echo were also normal. So from these clinical and radiological findings, we came to the conclusion that this patient had a bilateral corticobulbar tract involvement with bilateral human weakness of 5, 7, 10, and 12 causing anarthria. And imaging showed bilateral centrum semioval infarcts. And he had the vascular risk factors of newly diagnosed diabetes and hypertension. So we taught them NG feed, speech and swallowing therapy were initiated, and he was discharged on aspirin, clopidogrel, xylostazol, and hydrostatins. So at review, when he had come back after 3 days, the patient was able to swallow. There was no drooling of saliva, and he was able to make a few sounds. We were unable to find any case reports of isolated bilateral central semilunar infarcts which presented with anarthria, but there were a few reports of patients presenting with hemichoria and with hypoglossal paralysis following infarcts in this area, but these were all unilateral lesions. There's also one case report of a patient presenting with similar cranial nerve palsies who was found to have bilateral orbicular syndrome. But this is a cortical infarct, while our patient had a subcortical infarct. The centrum semioval is the core of the hemispheric white matter. This is the central white matter substance of the cerebral hemispheres. And though vascular changes in this has been emphasized in dementia, stroke from acute infarction in this is less well documented. And the blood supply to the centrum semioval is different from the cortex and from the other parts of the hemispheric white matter. And acute strokes which selectively involve this have rarely been reported. A bit about the blood supply of the cerebral parenchyma. So there is the basal perforating arteries which arise from the stem arteries, that is the ACA, MCA, and TCA, which perforate the base of the cerebellum to supply the corpus striatum. And then these give the superficial cerebral arteries, which are the pial arteries, which arise. So the pial arteries go like this, which arise distally from the stem arteries. And these pial arteries are of three types, that is the intracortical, subcortical, and the medullary arteries. So these medullary arteries are what supply the centrum semioval over here. And these are all end arteries which do not make functional anastomosis. So rather than watershed arteries, they are junctional areas. So this is the centrum semioval blood supply. So from the superficial pial branches of the MCA through the perforating medullary branches, which go the superficial pial arteries are these which give the medullary branches which go like this, which goes towards the lateral ventricles. This is a cadaveric arteriography which is done showing the medullary arteries, which are these small vessels, which is these. So there are four types of medullary artery infarcts which are described in the article. First is the ischemic leukoariosis, which is due to the dysautoregulation of cerebral blood vessels. The second type is individual medullary arteries. This is what we consider our infarcts to be, but these were more linear. And the third type are deep watershed infarcts, and the fourth are territorial infarcts. So the medullary arteries have not received as much attention in field of stroke, probably because they are too small to be seen with the current clinical modalities. But many cerebral ischemic diseases are closely related to the medullary arterial circulation. And these superficial perforated infarcts usually have a lower NIHSS score and a more favorable outcome. Radiologically, the pathogenesis and etiology is not definite, but most common considered is embolic and then large vessel and heart disease. As a patient had bilateral central semioval infarct with involvement of the pseudobulbar fibers, we try to read a bit about the arrangement of these fibers in the centrum semioval, but there's not much data regarding this. We have data regarding the arrangement of the corticospinal tract fibers in the centrum semioval, which we read about in these reports. So the trajectory of the upper limb and lower limb fibers in the centrum semioval was found using a tractography, and it was found to have a predictable course, which could be extrapolated by an arbitrary line between the anatomical landmarks, which were the cortex and a plane between the anterior and posterior commissures. But such data was not available for the corticobulbar fibers in the centrum semioval. In this cortex, as seen in the homunculus, we assume that the corticobulbar fibers are arising more laterally compared to the fibers to the upper and lower limbs. And when we look at the internal capsule, the corticobulbar tract is more anterior and can be extrapolated towards the cortex, like in this diagram, through the centrum semioval. And this also fits in with the location of our infarct. So based on the bilateral MRI findings with these deficits in the bilateral corticobulbar fibers, we presume that the centrum in the centrum semioval, the corticobulbar fibers are in this trajectory, while the limbs are located more posteriorly. So this is a diagram of which we assume the location of the infarct in our patient, and hence where the corticobulbar fibers may be passing through in the centrum semioval. So the cingulum was more medial, the superficial longitudinal fasciculus was lateral, and coronary aorta was normal. Thank you.
Yes. This is an extraordinarily interesting case. I haven't seen even a unilateral presenting with this stroke. This is bilateral, one after the other. And the etiology is obscure because he just has mild abscess and hemorrhage. We have just done a vasculitis workup. We haven't got the results yet. So many interesting points which is covered. So there's actually we know the arrangement of tracts in the internal capsule. Actually, she did a lot of work talking to the 50 about neuroanatomy and all that. And we know where the homunculus, where the fibers of the face are, where the cortex, the facial area is. But as she said, we really don't know. I mean, what the P also said is, we'll have to extrapolate. We know where it's in the capsule, we know where it's in the cortex. We presume it's posterior to the where our infarcts are, the corticospinal tract to the limbs. What is involved in our case is the corticobulbar tracts. So what he's got is something like a bilateral opercular syndrome, but the involvement is in the centrum semiovale and not in the cortex. That must be also supranuclear. That must be also progressive supranuclear palsy is a supranuclear palsy. Yes. That must be also supranuclear. I think we haven't found a case like this anywhere in the world. So it seems to be the first. So I've told it right it up.
Any other questions or the comments? Anything? I think we have reached the end of today's clinical meeting. All 5 of you had presented wonderful cases, and stick to the